Hello everyone. Today I am starting this series of case discussion, and I told you that we are going to be discussing the cases, the common cases that are kept in your exam, and this would be more of a mock viva kind of a thing, because this is something that I don't expect that you will make a mistake in your theory exams. These are very easy topics. These are the topics that you do day in day out in your theater. But today we are going to start discussing their practical aspects, what is expected from you in an exam in a viva. And I wanted some volunteers, and Dr. Krutika has gladly accepted to be the first volunteer, and she is today presenting a case of chronic kidney disease. And so we are going to start the discussion with she first presenting her case, and then we are going to take up from there and we will do a mock viva for this particular case. So good morning, Dr. Kritika, welcome.
Good morning, sir.
So you can start with your case, and
Okay,
I
sir.
will not interrupt you. So you can just continue
Hmm.
describing your entire case.
Okay, sir. Um, I will start the case.
Yeah.
A 70-year-old male from Calicut, manual laborer, presented with chief complaint of recurrent episodes of fever, vomiting, and abdominal pain since 2 months. Patient was apparently all right 2 months back. He developed fever since 2 weeks, which is low grade, intermittent in nature, with no diet urinary variation. There are no aggravating factor, and fever is relieved by medicines. Also, complaint of vomiting, which is non-projectile, usually occurs after taking food, fatty meals, non-bilious in nature, and is associated with food particles. There are no aggravating and relieving factors. It is associated with abdominal pain in upper abdomen, colicky in nature, aggravated after intake of food, and it relieves spontaneously in between. Patient also gave history that he was diagnosed with renal disease 2 years back. On further evaluation, there was frothy urine and swelling of hand and feet, and decreased micturition since 2 years. He was on further evaluation. He told he was on hemodialysis through right IJV once a week 6 months back. Now done 3 times through AV fistula in left forearm. Last dialysis was done yesterday. There is no history of dyspnea, chest pain, palpitation, generalized pruritus, no history of easy bruisability, no history of fatigability, seizure, memory loss, or altered sensorium. Past history, patient gave known case of hypertension since 3 years and diabetes since 1 year. He's taking two antihypertensive medications, some OHA drugs and insulin for diabetes. He previously he history of personal history of frequent hospitalization in past for dialysis, uh, no history of blood transfusions in past. Sleep and bowel habits are normal. Urine output is decreased as per the patient since last 2 years, so it is decreased to 2 to 3 times in a day from previous history. On general examination, patient is conscious, oriented, and irritable. Average build, pulse 90 per minute, regular. All peripheral pulses are palpable. AV fistula present on left forearm, brood present. Blood pressure is 140 by 90 in sitting position. Respiratory rate 15 per minute, regular abdominothoracic. There is no pallor, icterus, clubbing, sinuses, or lymphadenopathy. On airway examination, Malampati grade 2. Mouth opening is adequate. There is no loose teeth or protruding teeth. TM distance more than 6 centimeter and extension is adequate. Spine is calcified and there are narrow spaces. On abdominal examination, there is tenderness in right hypochondrium, no abdominal distension, no guarding rigidity or organomegaly. Hernial orifices are normal, bowel sounds are normal, no significant abnormality. Respiratory examination, air antibilaterally equal, no adventitious sound heard. Cardiovascular examination, S1, S2 heard, no murmur present. CNS conscious oriented, or reflexes are present. Diagnosis: a 70-year-old male, known case of chronic renal disease on hemodialysis, came with complaint of fever and right hypochondrial pain. Is most likely suffering from cholecystitis.
Perfect. So you presented a very uh, good case. You gave me everything that I needed. But let's now start the discussion. So I will first start by asking you, is there a significance of knowing the name of the patient in your history taking?
Name, in this CKD patient, I don't feel there's significance for the
So you
name.
don't want to have a name of the patient. You think that doesn't make a difference in your
That interaction that makes a better patient
yeah.
feels more comfortable to talk
So
with
for
us.
building rapport, you need to
Rapport.
know the name of the patient. Also, name tells you about the community of the patient, more or
Patient.
less.
Yes.
And then there are certain community related diseases
Hmm.
which can be anticipated. Can you give me an example of a community related disease? If you know the community of a person, you might anticipate a complication or a disease.
For example, in their consanguineous marriages in Muslim religion, so some disorders are more
Very good.
common in that.
So Parsis, not exactly Muslims, but Parsis, they are
Hmm.
known to marry consanguineously. And
Consent.
whenever there is consanguineous marriage, there are chances that autosomal recessive diseases will now start expressing in the
Hmm.
alternate generations. And we
Hmm.
have an array of autosomal recessive diseases which can present with syndromic problems with the patient, even having a chronic kidney disease, which is a part of a bigger syndrome, which is a autosomal
Okay.
recessive condition, right?
Hmm.
Also, name is very important for rapport building. So irrespective of whether
Hmm.
you feel that the name is required or not, you always
Hmm.
start with describing the name, age,
Hmm.
place, and if
Hmm.
at all the patient reveals, then the caste or the
Profession.
religion of the
Hmm.
patient,
Hmm.
because
Hmm.
caste or religion tells you about one, the area that the patient is belonging to, and
Hmm.
two, any specific food habits that are related to that particular caste,
Hmm.
which helps you understand certain conditions that are happening with the patient. All right. So the first part is the patient details. So you
Hmm.
had a 70-year-old patient who presented to you with chief complaints of
Fever, vomiting, and abdominal pain.
fever, vomiting, abdominal pain. What came first? What came later?
Fever followed by vomiting and abdominal pain
So
simultaneously.
everything has to be in chronological order, from the
Yes.
last thing to the most recent thing. So first came fever, then vomiting, then abdominal pain. All right.
Hmm.
Then you
Hmm.
described the fever, vomiting, and abdominal pain in terms of what parameters?
Onset, progression, duration, aggravating and relieving factors.
Very good. So onset, duration, progression, nature,
Hmm.
aggravating factors, relieving factors, and any specific correlation.
Variation.
Yeah,
Correlation.
any specific correlation. These are the 5-6 things in which you describe your history of presenting illness. So your
Hmm.
patient presented with fever, vomiting, abdominal pain that had a particular correlation with food and
Hmm.
more or less did not have an aggravating or a relieving factor. So
Hmm.
what did you assess from this particular history? What is the
Uh,
patient having? What are your
I, I,
differentials at the level of history? Differential diagnosis. See, we go step by step. All right. So you presented
it,
a case of
hmm.
fever, vomiting, abdominal pain. I am
Dominant.
still at this level only. When I am
Hmm.
taking a case and the patient comes to me and tells me I had 4 days of fever, 3 days of vomiting and abdominal pain, I have yet not asked him anything about anything, whether past history, family history, medication history, nothing. At this point, what should be the things on my mind?
There can be some obstruction, uh,
Obstruction, very good.
uh, cholecystitis, which is common.
Okay.
Uh,
Cholecystitis, what else?
some gastritis.
Gastritis, very good. What else? Fever. Does fever has a significance for you?
Yes, more it's an infection,
Infection.
most likely
Are
infection.
abdominal infections common in India?
Not
Abdominal infections, routine abdominal infections, are they common in a
routine
country like India?
gastritis are
Yes. And
common.
what is the most important thing that these abdominal infections are related to?
Loose motion, uh,
They are related to the type of food that the patient is
food in
consuming.
particular.
If someone comes to you with fever, vomiting, abdominal pain, the first thing that comes to your mind is a routine gastroenteritis. And the most common cause of gastroenteritis is some infected food. So the next thing should be ruling out infective cause by asking a history of food intake. Now, idea is for every complaint, you have potential 2 or 3 or 4 differentials in your mind. Now, to come to a diagnosis, you have to use negative history to rule out other things. So you told me obstruction, you told me cholecystitis, you told me gastritis. Am I right?
Yes,
Now
sir.
you have to come to one potential diagnosis. So tell me what all will you, how can you rule out obstruction, cholecystitis, gastritis?
Outside food history.
Outside food history.
Then history of any abnormal bowel movement associated with it.
Okay, so history of diarrhea,
Diarrhea.
dysentery, melena. Very good. What else? How will you rule out obstruction?
Abdominal distension.
How will you rule out obstruction on history? We are still at history. So we are only going to keep talking to the patient. We are not touching the patient. So we are not examining. If we are not examining, we can't comment about distension. Understood? Distension is a part of general examination. At the level of history, how can you rule out obstruction?
Unable to pass flatus.
Flatus and feces.
Motion.
So you ask about bowel history. Does the patient pass bowel or feces in the last 2, 3, 4 days of history or not? If he has passed the bowel, if he had a bowel movement, that means it is not obstruction. All right. Then how will you make sure that you rule out other causes of acute abdomen? Can you tell me common causes of acute abdomen apart from cholecystitis? Appendicitis, right? You can have pancreatitis. All right. Obstruction, you have already told me. And
acute hepatitis.
And you can have esophagitis, GERD, gastroesophageal reflux disease, right? How can you rule them out? Simply by looking at the location of the pain and transmission of the pain. Where is the pain of appendicitis happening?
Hypochondriac.
Right hypochondriac,
Iliac
which radiates towards the umbilicus. Right hypochondriac radiates towards the umbilicus, not hypochondriac, right iliac. Right iliac radiating towards umbilicus. Is the patient having that? No, he is having right hypochondriac pain. How can you rule out esophagitis?
Epigastric.
Epigastric, aggravated by meal, relieved by drinking cold things like cold water, cold milk, and being in supine, in propped up position. How can you rule out what was the third thing? Yeah, pancreatitis. So pancreatitis pain, it transmits backwards towards the interscapular region. That is the transmission of pancreatic pain. So there will be diffuse abdominal pain that goes behind the interscapular region. So I'm just trying to tell you that everything that you have to say has to be associated with differentials, and differentials have to be ruled out with their associated negative history. All right. And everything has to be described in chronological order from last to first. All right. Right. So you moved on to the next part. What was the next part?
Next part, patient gave history of some chronic renal disease 2 years back, and then he has associated swelling, and he started with hemodialysis through IJV cannula, and then shifted to AV fistula.
Very good. Then after that, what did you describe?
Negative history.
Yes. Then what did you describe in negative history?
So now, after discussion with you, first I will say there's no history of food intake. There's no history of there's history of there's history of he passed flatus. There is no associated melena. Then
so what you are doing is you are First describing the HOPI, history of presenting illness, then you are giving something about CKD and then negative history, while
Yes, sir.
negative history is a part of your HOPI. For every single complaint, you write the associated negative history or HOPI 3 complaints and their negative history after that. All right.
Sir, my question is one query. When I've mentioned dialysis, so there are so many complications and comorbidity associated with dialysis. So where should I rule out?
Yeah.
For
So we'll
example,
come to that. We'll come to that in a minute. Let's first understand that HOPI and negative history should come one by one. All right.
Okay.
So you ruled out the potential causes of fever, ruled out vomiting and abdominal pain. Now, tentatively in your mind, you have a intra-abdominal problem. It could be either a pancreatitis or it could be cholecystitis or it could be appendicitis. But we are kind of coming to the idea that it looks like it is cholecystitis. All right. Then what did the patient tell you?
That he had some renal disease diagnosed 2 years
After renal
back.
disease, what did he tell you?
That for that there was swelling associated with it.
Understood. Next complaint.
Then dialysis history, and after that it
Next.
would pass his hypertension and
Since
diabetes.
since
3 years, hypertension
okay.
since 3 years and diabetes since 1 year.
So
For which is
once again, if fever, abdominal pain and vomiting is what the patient has come to you for, so this is your history of presenting illness. Apart from this, everything else is a past history. And again, the past history has to be described chronologically. So what came first? Hypertension. Then what came?
Diabetes.
CKD.
CK.
Because 2 years back you had
2 years.
CKD. And then what came? Diabetes. So then you start with history. The patient gives a previous history of or past history of hypertension since 3 years, taking medication 2 to 3 times in a day, regular, well controlled, not associated with any other complications. The patient gave a history of vague renal disorder that was associated with swelling in limbs and facial edema, for which he consulted to a hospital and was told that he has a kidney failure, for which he was started initially on medical line of management. Then he was started on hemodialysis using a neck vein on the right side and later on using a AV fistula on the left forearm, right?
Yes, sir.
Left forearm. The patient doesn't give any other complications associated with the development of this kidney disease, and the patient is on regular dialysis 1 to 2 times in a week since last 6 months. Understood? And then the patient presented with a history of diabetes since 1 year, for which he started on some oral medication and the sugar was not getting controlled. So 3 months back, he started on IV or subcutaneous, mostly subcutaneous insulin 2 times in a day. Now well controlled, not controlled, depending on what the patient is telling you. Understood? So remember the chronology. Everything has to be chronological. History of presenting illness, chronologically negative history. Past history, chronologically. Along with that, your association of that past history with complication, any history of medication, any history of hospital admission, any history of hospital admission due to complications, and the control of past condition. Understood? This is how you present a case.
Sir, if there is associated dyspnea or fatigability or anything associated with CKD, so I will mention that in past history only?
Yes, it will be a negative history of past history. So when you are describing CKD, then you go on to describe the negative history of that CKD. But if the patient is not giving you any other history, you can simply write no history of chronic obstructive pulmonary disease, no history of asthma, no history of coronary artery disease, no history of angina on exertion or rest, no history of PND, orthopnea, pedal edema, no history of restricted movement. The patient is able to do his activities fine. So this rules out most of the common conditions that are associated with the CKD induced coronary or a cardiac problem. And so CKD, yes, CKD induced diabetes, diabetes induced neuropathy or nephropathy. So for neuropathy, autonomic dysfunction, you can always describe that the patient shows no history of orthostatic hypotension. Okay.
So whatever I've told in my negative, that should come in past history basically.
Negative history means ruling out.
ruling
So
out.
for every condition, you have 2-3 differentials. You want to rule out the other differentials to come to your final diagnosis. So always history, negative history, history, negative history, history, negative. Don't make a negative history separate column in your exam. What will happen is you might not be able to reach till that point. The examiner will get distracted somewhere and he'll pick up a point. He will think you have not taken that negative history, while according to your case, your negative history is going to come later on. So don't wait till that time. Give the history, give its negative history. So he will immediately ask you, what is your idea of asking history of paroxysmal nocturnal dyspnea in a patient with CKD? So what will you answer? What is the significance of PND in CKD?
It is associated with coronary artery disease. CKD patients
Okay.
are associated with coronary artery disease, so we are ruling any cardiac.
Yeah, but then what is the significance of PND with coronary artery disease?
So
And is there
PND
any correlation between CKD and coronary artery disease? Is CKD a
yes.
risk factor for coronary artery disease?
So CKD is associated with coronary artery disease. Since this patient is already diabetic, so there are chances of macrovascular diseases. Also, CKD are associated with cardiac dysfunctions.
Tell me pathophysiology of coronary artery disease in a CKD patient.
Sir, CKD, there is hypertension, hypertension. This could be one reason. Second thing, there is chances of LVH because of pressure overload and volume overload. So,
But how come CKD will cause pressure and volume overload?
when there is CKD, RAS activation is there. When GFR decreases, RAS activation is there. Fluid overload. This causes hypertension. So this, because of volume overload, there could be LVH, and also because of and there could be pressure overload also. So these things can lead to
So tell me,
LVH.
if there is LVH, would you call it a coronary artery disease?
No,
No. So what would you call it?
ischemic. It can lead to ischemic
You
heart.
will call it hypertensive cardiac
Heart
disease.
disease.
So he is suffering from a cardiac problem, which is not a direct complication of CKD. It's a complication of a complication. Hypertension can cause CKD and CKD can cause hypertension, isn't it? So
Yes.
you don't know what came first. According to your history, hypertension came first. So hypertension induced cardiac abnormality that can cause decrease in ejection fraction, which can cause left ventricular failure. LVH doesn't present with PND. LVF presents with PND. So your history has to be directly correlated to the pathophysiology. So don't just say CKD causes coronary artery disease. There is no direct mechanism between CKD and coronary artery disease. Hypertension is one of the primary reasons for development of CKD. Hypertension causes chronic arteriosclerosis. This arteriosclerosis can later on present as coronary artery disease, and this coronary artery disease can lead to reduction in ejection fraction of the heart, causing left ventricular failure. Left ventricular failure can present to you with PND orthopnea. Understood? So you have to calm down while you are describing these things. Everything is pathophysiology wise. So when you say that I want to rule out cardiac problems, then you can have cardiac mechanical problems, you can have cardiac coronary problems, and you can have cardiac conduction problems. So always think of heart as three things: muscle, artery, and electricity. Arrhythmias will be seen when you have electrolyte disorders. You have hyperhypocalcemia, isn't it? Which is common with CKD patient. So patients on dialysis are prone to arrhythmias. Why? Because their myocardium is now sensitized and they are having more electrolyte fluctuations. All right. Two, structural problem. Can structural problem happens with CKD? Yes. Chronic hypertension can cause left ventricular hypertrophy, which can present with left ventricular failure. Two, CKD causes salt and water retention, which causes increased intravascular volume, which puts the pressure on right heart, which can cause right ventricular hypertrophy, cor pulmonale. Three, hypertension is a risk factor for coronary artery disease, which can present to you with ischemia, Silent MI, why? Because even the neurology is decreased, so the patient doesn't understand that they have chest pain. Also, diabetes complicates the development of coronary artery disease, which in your patient is a contributory factor. So the patient is at risk of silent ischemia. Understood? So every system you have to think in terms of in terms of what you can say systems, and every system has a correlation to the comorbidity. And never forget this point, that you always as an anesthetist talk about the effect of disease on anesthesia and effect of anesthesia on the disease. Understood? Our concept is very simple. Effect of CKD on anesthetic agents, effect of anesthesia on CKD. This is it. For every comorbidity, every coexisting condition, this is what I want from you. All right. Effect of the disease on the anesthesia, effect of anesthesia on the disease. All right. Let's move on. Let's talk about dialysis. Tell me, what were you telling about dialysis?
He was on hemodialysis through right IJV once a week, 6 months back, and now 3 times through AV fistula in left forearm. Last dialysis was done yesterday.
Okay, what is the significance of knowing about this dialysis?
So when dialysis, so we remove ultrafiltrate, so that helps us to know the how much volume has been removed. After that, we should know the last dialysis duration, since how and last dialysis duration and surgery duration. So because there are large fluid shift, so we try to have at least 4 to 6 hours gap after last dialysis. Also,
Why specifically 4 to 6 hours?
because large fluid shifts and electrode abnormalities may occur in these 4 to 6
So they
hours.
don't happen after 6 hours of dialysis?
But majorly,
No, but why so specific 4 to 6 hours? Why can't it be 12 hours after the dialysis or 24 hours after the dialysis? If your patient
we
is getting dialyzed 3 times in a week, that means if he gets dialyzed today, till day after tomorrow evening, he is okay. That is why he's not going undergo dialysis again. So then why are you saying that there should be a gap of 4 to 6 hours between a surgery and your last dialysis? What will happen?
minimum gap.
What will
Minimum
happen?
gap.
Yeah, I understand minimum gap, but why 4 to 6? Why that minimum gap is not 12?
Don't know.
So that has something to do with how you do dialysis. What is the most important thing that you do when you are dialyzing a patient? What do you use? You use a machine.
Yes.
What is the function of dialysis machine?
Basically removing the toxins and basically exchanging.
It
It's removing
is
the
it is
toxin.
doing the work of kidneys. So it is getting the
Kidney
blood out of the body.
body.
It is extracting all the nitrogenous waste, all the
Hmm.
excess waste, all the excess fluid that has been accumulated in the body, put that back in the body. You think you need something extra when you are taking the blood out of the body and putting it back? Whenever
Dilys
the
fluid.
blood has to come out of the body, will it remain like a blood? Will it remain fluid? If you cut yourself, then the blood that is coming out, will it keep flowing like blood outside also, or it will clot? It will clot. So when the patient's blood is coming out of his body and going into the dialysis machine, why is it not clotting?
Hip, heparin.
Because you are using an anticoagulant.
Coagulant.
What is the most common anticoagulant that you use in dialysis?
Heparin.
What is the half-life of heparin?
Don't know.
About 1.5 hours. And you need at least 3 to 5 half-lives to pass for the complete action to get terminated. That is how much? 4 to 6 hours. So because you don't want excess bleeding during the surgery, that is why the minimum gap between your last dialysis and your surgery has to be 4 to 6 hours, because you are using heparin. You can do it after 12 hours also, 24 hours also. But the minimum gap has to be 4 to 6 hours because of heparin. Understood? That is the reason why you keep this gap. So the type of dialysis, the site that you have used, what is the significance of the site?
So we usually we can use right IJB, we can use femoral as well, but we prefer, so femoral we can avoid because there are always, if patient go for further renal transplant, the iliac vessels are used in anastomosis, so we can avoid femoral. Right IJB we can right or left IJB we can use, and apart from that, we can use AV fistula.
What is the
These are the
significance
sites.
of AV fistula?
Mm.
So moving on, this is not important right now. We'll discuss it
Yes, sir.
later on when we discuss anesthetic management of AV fistula. So
Yes, sir.
very good. Now, anything that you want to talk about when you spoke about diabetes?
So diabetes is the most common cause of
No. We are still at
surgery.
history. So I'm not asking you a question on diabetes. I'm
Okay.
asking you in your history, what are the things that you spoke about in diabetes?
So diabetes, I will ask if there is orthostatic hypotension, autonomic dysfunctions. I will see is if there any microvascular complication of that. So I will ask is there is a palpitation, resting tachycardia, orthostatic hypotension. Then is there any bowel incontinence history? These are the things I will ask.
Okay.
Um,
Anything very, very important
neu
that you need to ask?
neuropathy. Neuropathies
So
are
you are going in the complications of diabetes and you are ruling out micro and macrovascular complication. But tell me, what is the most common complication in a diabetic patient who is on insulin therapy?
hypoglycemia.
Is it
Frequent,
important to ask the history of
yes.
hypoglycemia?
Mm.
Why is it important to ask the history of hypoglycemia?
So, because we can dose adjustment of.
So that is your diabetic control. But
Mm,
on history, your diabetic control is of no value because you don't have numbers. You have not touched the
mm,
patient. You have not taken the prick and taken the blood sugar, right?
mm, mm,
But still, you are asking history of hypoglycemia. See, intraoperatively, you are going to measure blood sugar every hour and you
mm,
are going to make sure that the patient always receives a sugar containing fluid. So the risk of
mm,
intraoperative hypoglycemia is negligible.
mm.
Then what is the significance of asking history of hypoglycemia?
Hypoglycemia itself can lead to so many complications. We so don't know.
Like for an example,
The conversions, hypoglycemic patient can get disoriented,
okay,
altered sensorium.
very
So
good.
we need to know.
So hypoglycemia primarily tells you about the diabetic control of the patient, whether the insulin that the patient is taking is excessive or not.
Mm,
Two, it tells you the number of hypoglycemic episodes, tells you that how less hypoglycemic awareness that the patient is having. Severe diabetic patients have very low hypoglycemic awareness. They are so used to hypoglycemia that their body doesn't respond to hypoglycemia that well. So
mm,
now when you have patients who have multiple episodes of hypoglycemia, then they will always tend to underestimate their problems because they will have unawareness for symptoms. They will have unawareness for angina. They will have unawareness for the seizures, the aura that is coming with the seizure. So they are neurologically always depressed. So when in the post-operative recovery, you are anticipating a complication, these patients will tell you less about the complications. That is the
mm,
importance of hypoglycemia. And most importantly is the diabetic control. More risk, more episodes of hypoglycemia, that means poor diabetic control. See, good diabetic control has a very stable course of action of insulin, that you give 10 unit of insulin and the sugar will go down by 250 milligrams. But patients
mm,
who have very poor control of insulin, there you will give 5, it will go to 350, you will give 10, it will go to 30. So there is a wide fluctuation. So it tells you that
mm.
how bad is your diabetic control. All right.
So if there are multiple episodes in past of hypoglycemia, so it's easier for them to tell the complication.
No,
Right? This is what
it would be difficult for them to tell the
difficult.
complication
Okay.
because now their hypoglycemic awareness is lesser. Now their
Okay.
brain is inherently depressed. The
Mm,
brain is so used to less
okay.
glucose that the brain doesn't respond when there is less glucose.
Mm,
You will be
mm,
hungry for 2 hours and you will start getting irritable, start shouting at everyone. You will show signs of hypoglycemia. Somebody
mm,
who is a diabetic from 25 years has had 50 episodes of hypoglycemia with a blood sugar of 35. He will not even say anything. He will just keep sitting like this. You will realize
Hmm.
something is wrong, you'll prick and you'll say, oh, he's hypoglycemic. Understood? So
Okay, sir.
hypoglycemic
Yes.
unawareness bolte hain usko. All right?
Hmm.
Sure.
Yes.
Very good.
Hmm.
Moving on. So you presented your history. Now, is there
Hmm.
any other history point, if at all you have time in the exam,
Hmm.
any other things that you want to present in the history? You gave
Sir, I will.
HOPI, you
I
gave
will ask.
negative history, you gave past history,
Personal history and
personal
family history,
history, personal, family, medication, and
medication.
history of admissions.
Hmm.
Right? Because you have a
Hmm.
chronically ill patient. CKD patients, they keep coming in and out of the hospital. So you just mention the number of times the patient has been admitted for a complication
Hmm.
of dialysis. All right. Chal, moving
Hmm.
on to general examination.
Okay. So patient conscious, oriented, irritable. Average build pulse is 90 per minute regular, and all peripheral pulses are palpable. AV fistula present on left forearm. It's working. Brood present. BP 140/90 sitting position. Respiratory 15 per minute regular. Abdominal thoracic. No pelvic test. Clubbing sinus and lymphadenopathy.
So since your patient is diabetic, don't you think you need both supine and sitting blood pressure?
Yes.
And what is the
And
significance of that?
orthostatic hypotension.
Is a
So,
sign of
uh, diabetic autonomic neuropathy.
what else is a sign of diabetic autonomic neuropathy? What are the tests for diabetic autonomic neuropathy?
Sir, heart rate variability test. There's cardiovascular reflex tests, Valsalva test, table tilt test, orthostatic hypotension, then pressure test, cold metric test, then sodomotor test, thermocompensate
So you know that there are tests to test the sympathetic system and tests
sympathetic
for
system,
parasympathetic system because both get affected in diabetic autonomic
diabetic.
neuropathy. So if you
Okay.
have a diabetic autonomic neuropathy, suppose you get orthostatic hypotension in a patient who is CKD, what are the anesthetic implications?
Uh, Autonomic neuropathy. So, the blood pressures in these patients are very labile. So, for example, it's a laparoscopic surgery when we using a port or there's increase in positive pressure, ventilation, intrathoracic pressure. The changes are going to be hemodynamic changes are going to be very labile. So, compensation is not there in these patients. When we are giving a sympathetic block, there's there are no there's vasodilatation, but there are no compensation because of um,
So
autonomic neuropathy.
labile hemodynamics. What else?
Yes, sir.
One is labile
Uh,
hemodynamics. It could be either during the change of position, it could be either during pneumoperitoneum, it could be either during a central neuraxial block. I understand.
hmm.
Labile hemodynamics. What else?
It can be associated with when we are giving if there's already peripheral neuropathy in these patients and we have not documented, we have given a block. So it can get confused with this complication with our block. So we should medically examine the patient properly and document it prior if there's associated neuropathy in these peripheral neuropathy in these patients.
So risk of exacerbation of neuropathic symptoms or not documentation of neuropathic symptoms later on leading to medical legal
Hmm.
troubles. Very good. What else? See, you are saying diabetic autonomic neuropathy. So the
Hmm.
answer lies in the question itself.
Hmm.
Diabetes autonomic. What is your autonomic system involved in?
Sympathetic, parasympathetic.
Sympathetic, parasympathetic. You spoke about one aspect of sympathetic system, that is hemodynamics.
Hmm.
You spoke about neuropathy. Now
Hmm.
what else is remaining?
Parasympathetic.
Parasympathetic. So tell me what is the significance of parasympathetic system for an anesthetist? Because that will also get affected.
Vagal heart rate.
That you have already spoken about in the labile hemodynamics, right? What else in parasympathetic system? Is it something to do with the temperature control of the patient? Will they have normal temperature control in the body? Will they sweat normally, which is a part of parasympathetic nervous system?
No,
Will the
no. There is
temperature variations that happen with the patient will be normal? Will
no,
they be able to compensate for hypothermia that happens intraoperatively? No.
No.
So again, I told you, always divide a system: diabetes, autonomic system, neuropathy. You spoke about diabetes, you spoke about neuropathy, you have to speak about autonomic. In sympathetic system, you spoke about labile hemodynamics. So change of position has to be slow. Pneumoperitoneum has to be slow. Sympathetic blockade will always be exaggerated. So you have to keep your patient hydrated, keep vasopressors ready, and your patient will have poor temperature control. So patient will be more prone to hypothermia and will show less responsiveness to hypothermia by shivering. So you have to maintain normothermia actively by forced air warmers. Understood? That is the significance of diabetic autonomic neuropathy in your patient during your case. All right. Chal, moving on. What else?
Airway examination.
Yeah, come to airway. Let's discuss airway.
Malampatti grade 2, mouth opening adequate, no loose teeth, no protruding teeth, PM distance more than 6 centimeter, and there's adequate neck extension.
Okay. So when you start airway examination, do you always start with Malampatti directly?
No, I've examined patient in sitting position.
Yes. So how you describe your airway is of paramount importance, because this is the part from where the examiner has now become super intelligent. Before that, whatever I have spoken, he might be asking you these things, he might not ask you these things. But now he is going to ask you everything. So here you can't say things in a way where, you know, things are vague. Now, airway examination, you have to be very thorough. So how did you examine the airway? You started by
sitting position. So my eye should be at the level of patient's mouth, and then
examine the patient in
I've
front
asked
of my
patient to,
eyes. Yes.
and I've asked the patient to open the mouth and without phonation to see the Malampatti score. Then
Very good.
I have seen if there is any loose teeth. If there's a
So
loose teeth, the
before you go
location
to
of
Malampatti and before you go to loose teeth, is there anything else that you want to look at?
facial abnormalities.
So always remember, discuss the airway in two parts: predictors of difficult bag and mask ventilation, predictors of difficult intubation. Predictors of difficult bag and mask ventilation are
Edentulous, beard, obesity, elderly. These are the
elderly, right? Predictors of difficult intubation are
difficult intubation. If there is
lemon.
protein, lemon criteria.
Lemon. Always talk in
Hmm.
terms of lemon. Everybody does
Yes.
lemon. You also do lemon. You first
Yes.
look at the patient. You describe any obvious signs of difficult airway. Does your patient has any obvious signs of difficult airway, like
No.
protruding teeth, like lot of beard, mustache, high ass palate, any facial trauma, any restriction of movement? No. So no signs of, no obvious signs of difficult airway. Then you go to next, that is evaluating the rule of 3-3-2.
3-3-2
That
rule.
is your
Um, thyroid, PM distance.
फर्स्ट इज ऑलवेज द फर्स्ट इज द मोस्ट इंपॉर्टेंट थिंग दैट यू डू. देखो इसमें यहाँ गलती क्या हो रही है कृतिका, आप टेंस हो जाते हो जब, तो आपको ऐसा लगता है मुझे कोई इंटेलिजेंट जवाब देना, इजंट इट? आपको ऐसा लग रहा है मैं कुछ मिस कर रही हूँ, जबकि व्हाट आई एम एक्सपेक्टिंग इज व्हाट यू डू इन द थिएटर एवरी डे. What do you do when you have a patient? How do you start your airway examination? What is the
I
first
will
thing
see
that you look?
I will see the incisor
सबसे
distance.
पहले आप बोलते हो मुंह खोलो, माउथ ओपनिंग. So when you do mouth opening, when you assess mouth opening, why not say mouth opening? Practical के लिए don't try to create new answers. Whatever you do in the theater every single day is the right thing to do, isn't it? तभी तो आपका पेशेंट जिंदा वापस आ रहा है ना. So the practice of anesthesia that you do in the theater is exactly what is needed to get the job done. So why not just talk about what you are doing? Why create new answers in your mind? That is where you get confused. That is where you get फ्रस्ट्रेटेड कि मुझे याद नहीं आ रहा, याद नहीं आ रहा. आपको जो आता है आपको वही बोलना है. सबसे पहले क्या देखा आपने? पेशेंट को देखा. कभी कभी आपको देख के समझ में आ जाता है ना, बुढ़ा है, बहुत बड़ी दाढ़ी है, बहुत अजीब से एक्रोमेगैलिक टाइप के फेशियल फीचर्स हैं, या बहुत मोटा है, एकदम थिक नेक है,
और वो चीक्स है.
आपको देख के समझ में आ जाता है अरे यार आज सुबेरे सुबेरे गंदा पेशेंट मिल गया. ठीक. फिर आप पेशेंट के पास जाके क्या करते हो?
माउथ ओपनिंग.
माउथ ओपनिंग, हेड एक्सटेंशन करके, थायरोमेंटल
हेड
डिस्टेंस,
एक्सटेंशन,
sternोमेंटल डिस्टेंस,
डिस्टेंस,
थायरोहायोइड डिस्टेंस, हायोमेंटल डिस्टेंस. Then you go on to मलम पट्टी,
मलम
then
पट्टी.
looking for signs of obstruction, that is epiglottitis, peritonsillar abscess, trauma, and then you go for range of motion. You said adequate extension. What does adequate extension mean?
So I can keep one hand on the chin and one on occiput, and I will tell patient to look up, and I will see if the alignment of the line, if it is occiput is at a higher level, then this means it is less adequate, and when it is occiput is below that chin line, so it is
So you have to
adequate.
describe the adequacy of extension and flexion. Adequate extension is what you described, or you take a proctor and you measure the angle if it is more than 35 degrees. And how do you describe adequate flexion? Chin can touch the sternum. Okay? Chin can touch. So airway, again, we'll do it next time. Again, try to do a better job with airway. Airway, you have to talk about everything in detail. You have to measure everything. You have to measure the neck circumference. You have to measure the mouth opening in millimeters. You have to take the angle through a proctor. There is no problem. If you spend 2 minutes, 5 minutes of time while you are doing airway assessment, there is no problem. All right?
Sir, one question. There's only 15 minutes in exam, and I find it very difficult to take everything in this 15 minutes, and we tend to miss out things. So, should we invest 5 minutes on airway? Because, sir, it takes 5 to 7 minutes for airway examination. You cannot, patient are not very trained. You have to tell, do this, do this. And then,
but you only tell me if you are an anesthetist examiner in the exam, what would you look at me as a student?
sir, I will look at airway, but examiner will accept that I am investing so much time and not
But you
detailing
have
other
taken a
examiners.
detailed history, and this is
Sir,
at
but
the
this
end
is so
of the
I have
history.
made this, but
We
in
understood.
practically,
Understood.
very...
Most of the time in the exam, you will have even lesser time than this. But all the relevant things would be in your mind, na? All the negative history thing, you just ask the patient. You don't write it there. You just keep on asking. You only write the airway examination technically. Otherwise, you don't write anything. Rest everything you can go in front of the examiner and just say it. क्योंकि वो आपका पेपर चेक नहीं कर रहा है. Most of the DNBs they don't even ask for a paper, है ना?
Sir, one more thing. If negative is, for example, I have a normal airway patient का कुछ भी problem नहीं है. Still, I should mention everything कि I look externally. I did 332 evaluation.
No, I
saw
examined the patient in sitting position at the eye level. The patient appears to have a normal airway. No obvious abnormality. Mouth opening is adequate. Thyromental distance is more than 6.5 centimeters. Adequate neck diameter. Neck circumference. Malampatti grade is 1. Adequate extension and flexion. The patient can touch the chin to the sternum, and the extension is more than 35 degrees. That's it. And no oral abnormality. Okay. That is all. So it took you what? Less than 30 seconds to describe it. Once you keep practicing normal ko bar bar in the exam, whatever would be the abnormality, you will highlight it more. Okay. Chalo. So you have done a good job with the case. Right? Now let's come to the main part. How will you manage this patient for a laparoscopic cholecystectomy? Describe me the anesthetic management of a CKD patient that you have for a laparoscopic cholecystectomy. Now start.
Okay. So there are some patient-related concern, there are surgery-related concern and pathology-related concern. So for patient-related concern, age-associated comorbidities, and these are going to be my concern, which is hypertension, diabetes, associated comorbidities. Then there is a surgery-related concern, that is duration of surgery and the intra-abdominal pressures. These are my concern. And then when I say surgery-related concern, pathology-related concern is I have to maintain a good mean arterial pressure of mean arterial pressure more than 65 to 75 mmHg. There is going to be upregulation of auto-regulation, so that is my concern. Then adequate hydration. There should not be fluid overload, and there should not be an end organ perfusion should also be maintained. I have to avoid nephrotoxic drug. I have to maintain euglycemic status of this patient. Repeated blood gas to so that electrolytes are normal, and these are my drug dose alteration, anesthetic drug dose alteration. So these are my pathology related concern in this patient.
Very good. Now, you have to understand the difference between concern and goals. ठीक है?
Hmm.
तो थोड़ा सा समझो. Concern is hypovolemia.
Hmm.
Goal is adequate hydration.
Hmm.
So when you start describing your anesthetic management in terms of concerns, then you only talk about complications. Like my concern, which is disease related, is the complications associated with CKD, that is diabetes, diabetic autonomic neuropathy, silent myocardial ischemia, left ventricular hypertrophy, left ventricular failure. These are your concerns. What are your goals? Maintaining adequate tissue perfusion, maintaining myocardial oxygen demand supply, maintaining the hemodynamic fluctuations because of diabetic autonomic neuropathy. Concerns are complications. Goals are what you do to avoid those complications. So while you are describing concerns, don't utter the words like I will keep my patient hydrated, I will check for multiple ABGs. Your goal is not to check for multiple ABGs. Your goal is avoid electrolyte disturbances. Your concerns are hyperkalemia, hyponatremia, hypocalcemia.
Yes.
Understood? Concerns are complications. Goals are what you need to do to avoid those complications. And then in the management, you go to specific part. Understood?
Okay.
So
Sir,
always
so my concerns,
start with concerns and their goals, and then go on to anesthetic management and divide your anesthetic. What I heard was you said multiple ABGs in a case of
frequent.
laparoscopic cholecystectomy.
No.
For me, that is the end of this Viva. I will pick up that word ABG and I will ask you, how many times have you taken arterial line in a patient of laparoscopic cholecystectomy? In a 40-minute laparoscopic cholecystectomy, how many ABGs are you going to take? And what are the electrolyte abnormalities that you are expecting in a elective patient of CKD who had a dialysis 12 hours back is now in your theater? With normal coagulation, normal electrolyte, everything, what electrolyte abnormality is going to happen in 40 minutes?
Yes, sir.
So remember, only utter the words, only utter the things that you can justify. Theory mein mat jao. What you did was you described theory to me. Theory said that you are going to do multiple ABGs to check for gas. But for a 40-minute laparoscopic cholecystectomy, कभी जिंदगी में arterial line लिया है क्या किसी? नहीं. So that is putting your foot in your mouth. ठीक है? नहीं करना ये, कभी नहीं करना है. ठीक है? स्ट्रक्चर्ड तरीके से बोलना है. हर एक में सिर्फ 2 पॉइंट बोलने हैं. कितने पॉइंट? 2 पॉइंट. My comorbidity concern, 2 point. My pathology concern, 2 point. My surgical concern, 2 point. They are relevant goals. When you go to anesthetic management, your pre-operative evaluation and preparation, your on-table monitoring, and on the day of surgery investigations, your pre-medication, pre-oxygenation, induction, intraoperative course, recovery, plan for post-op analgesia and complications.
So these comes in goals, na? All these things what you told.
No, this is anesthetic management.
Management. Okay.
ठीक?
So my concerns in these patients
are. वापस से describe the anesthetic management of a patient with chronic kidney disease, 3 times dialysis in a week, posted for a laparoscopic cholecystectomy. Take your time, 5-10 minutes. I'm not going to interfere at all.
Sir, concerns भी बोलना है?
सब बोलना है, जो आपको एग्जाम में बोलना है सब बोलना है.
ठीक है. So my concerns in these patients are age-related comorbidities. Then pathological concerns are hypovolemia, electrolyte abnormalities like hyperkalemia, hyponatremia, hypercalcemia, hyperphosphatemia, secondary renal osteodystrophy, secondary hyperparathyroidism, pulmonary edema, fluid effusion, fluid overload, then associated autonomic dysfunctions. Anemia, infection risk, and coagulopathy. These are my also gastroparesis in these patients. These are my concerns. After that, anesthesia management includes history taking. I will take a detailed history of this patient, dialysis history, route of history, duration of dialysis, and other comorbidities. After that, I will do pre-op optimization in these patients. That is electrolyte corrections, frequent electrolyte corrections in these patients. The and good good venous access and hydration status. These are my pre-op optimization. During anesthesia management, pre-op I will also antibiotic. Good antibiotic I will make sure it is there free of anesthesia management yeah, in the induction I so basically there are drug alterations to be done in these patients or drug dose alterations. So in the for induction I can use fentanyl. Remifentanil is a better option because it has esterase metabolism. L-fentanyl can be used, but we still, because of the availability, we most commonly we go ahead with fentanyl. For then propofol can these patients are more prone for hypotension. So if we are using propofol, we have to use in titrated dose. Thiopentone can be used in these patients, but dose is decreased. After that, for muscle when we are inducing this patient rapid, there is of aspiration gastroparesis, so rapid sequence induction to be done. If potassiums are less than 5.5, we can use succinylcholine. Otherwise there is risk of hyperkalemia, so we can use rocuronium in these patients. Rocuronium also has renal excretion. Those rocuronium can be used, vecuronium can be used. Atracurium and cis-atracurium can be used. Atracurium has one apoptogenic potential, tadosine. Both of them has Hoffman's elimination. Atracurium and cis-atracurium. So cis-atracurium does not have any metabolite. So cis-atracurium is preferred over atracurium. When we are inducing ED95 dose, the initial dose needs to be 3 times more because there is increased volume of distribution in CKD patient. But when we are getting the subsequent top-ups, it needs to be decreased as per the elimination. After for analgesia management, I can intra-op, I can use acetaminophen. Paracetamol can be used in this patient. Apart from this, morphine is avoided because morphine produces one metabolite M3G, which can lead to respiratory depressions post-op period. So tramadol is also can be avoided because in patient with uremia, it can apoptogenic potential threshold is decreased. So tramadol can be avoided. Dynapar is we avoid nephrotoxic drugs, but if patient has been on dialysis, so we can give a single shot of diclofenac. This analgesia, apart epidural, since this is in this laparoscopic surgery, we don't need epidural. But if we need to put any other open surgeries, epidural, we avoid it because of there's abnormal platelet functions and coagulopathy is there underlying. So we avoid that. This is analgesia for post-op. This is intra-op analgesia. After that, extubation, we use we have the neomycin can cause um, more prolonged effect again. Uh, this is my intro management. And for post-op pain control, I can use fentanyl-based PCA pump. I can use again paracetamol, and I can give tab block as well as superficial in laparoscopy surgery. The best part is the pain is less as compared to open surgeries. So we can easily manage with paracetamol. But if patient is having severe pain and complaining, we can go ahead with superficial tab block or fentanyl-based PCI pump. So these are my uh, management of this patient. Also, fluid management is a very important thing. I need to hemodynamically, I need to keep MAP more than 65 to 75. 75. Since there's hypertension, there's upregulation of autoregulation, and we need adequate perfusion. Urine output monitoring is very important in these patients. Uh, Fluids, we can use crystal colloids we need to avoid because it causes renal dysfunction. Gilofuscin can be used. I need to RL can also be avoided because it can make cause to hyperkalemia. So plasmalites, isotonic fluid we can use. One more thing is monitoring, which I've missed. In monitoring, we will do standard ASA monitoring, ECG, pulse ox, blood pressure, good IV access. Since this is a small 40-hour surgery, we know we don't need a central venous access or art-line monitoring, and there should be always a high threshold for invasive procedures in these patients. Neuromuscular monitoring, again, it's a small procedure, so we don't need, but we may use neuromuscular monitoring for the use of relaxin and urine output monitoring. These are things in to be done in monitoring. These are my anesthesia concerns in CKD patient.
Post-op.
Post-op is post-op, their pain relief is important, and also we can if we suspect there is patient is showing any uh, post-op routine monitoring, we can give oxygen for some time. We can just put warmer so there is no again shivering, and analgesia and fluids, urine output monitoring. These are the basic things. Uh, since this is not a very big surgery that I'm expecting multiple fluid shift. Otherwise, if it would have been a lot of fluid shift, I could have done one blood gas to just see post-op assessment if there are any electrolyte abnormalities in the patient.
Perfect. So you have described the anesthetic management very, very diligently. Only thing is that because you are not practiced it enough, so your thoughts are faster than your words. You know, that happens when we have too much to tell, and we are thinking of the next point before we have completed the first point. So from the perspective of your anesthetic management, there is
Hmm.
pretty much everything that is supposed to be told in terms of heading you have told. Few
Hmm.
points that I won't agree to
Hmm.
is that when you are describing the effect of anesthetic agents and the effect of CKD on anesthetic agents, there you are describing that there would be prolongation of duration of action of drugs like fentanyl. So we have to use them carefully, cautiously. You have to avoid
Hmm.
morphine. But while you are in your post-operative analgesia, you are okay with using fentanyl PCA pump, which
Hmm.
would be an
See,
absolute no-no
I
in a
also have this
patient with
query, sir.
CKD.
Yeah.
Yes, in a patient with CKD, because PCA means patient can take 4 bolus doses every hour, and that
Hmm.
accumulation will later on lead to respiratory depression. So when
Hmm.
you are
Yes.
avoiding opioids because they can have prolonged duration of action, then you will
Hmm.
never use a drug like fentanyl PCA. All right. So you
Hmm.
go for multimodal, non-opioid based analgesia. You use
Hmm.
acetaminophen, that is paracetamol, which is safe. You
Hmm.
can use dexmedetomidine. You can
Hmm.
use lignocaine infusion. You can use regional nerve blocks like rectus sheath block and subcostal tap.
Hmm.
All right.
Yes, sir.
These are the things
Ah,
that you can use for
ah,
your postoperative analgesia, considering that the CKD of the patient might prolong.
hmm.
Also, you very well mentioned later on at some point of time that because the volume of distribution is higher, so you need a higher bolus dose, but lesser
Hmm. Maintenance.
maintenance dose. But when you spoke about thiopentone, you said you will require it in lesser doses,
Ah,
which in
sir.
fact would be required in
Huh.
higher doses because high
Sir.
volume of
Yes.
distribution, it's a highly lipid soluble drug. So again, bolus dose will increase,
Hmm.
but your subsequent doses will have to be decreased. But
Sir, I
because
have
we
this
are using
question.
thiopentone
Hmm.
only for
Fine.
induction, so
Hmm.
your dose will always be more than the normal dose.
Hmm.
But that more than normal dose will cause wide hemodynamic fluctuation. So is thiopentone a drug that you can use? No. You know that there are 15 drugs and their implications, but you don't talk about all of them. When I ask you anesthetic management of this patient posted for a laparoscopic cholecystectomy, you tell about which drugs are safe, which have to be avoided. So you start by induction. Propofol is safe. Higher loading dose is required for the action. The propofol has to be given in a titrated dose so that there is no hemodynamic fluctuation. All right. Muscle relaxant, scoline is safe if serum potassium is less than 5.5. Have to be avoided if we are doing RSI, if we have Sogamadex and a normal airway, then we will prefer rocuronium plus Sogamadex for RSI. ठीक? Then inhaled anesthetic agents. All inhaled anesthetic agents are safe, but we would want to avoid sevoflurane for the potential risk of compound A formation with soda lime. Although now we don't use soda lime in our closed circuits,
Hmm.
we use Emzob, which has no compound A formation, right?
Hmm.
Intraoperative course, you try to maintain the patient in adequate plane of anesthesia, keeping MAC 0.8 to 1 depending on use or not using nitrous oxide. Nitrous oxide is not contraindicated in a patient of CKD. You
Hmm.
maintain hemodynamics. You maintain a mean arterial pressure above 60 mmHg. maintain euvolemia, and maintain a urine output of more than 0.5 to 1 ml per kg per hour, keeping the patient sufficiently deep muscle relaxed as well as adequate depth of anesthesia, which can be monitored using depth of anesthesia monitors like bispectral index. You never say that I'm not going to use neuromuscular monitoring because it's a short surgery. Why? Short surgery patients don't need adequate reversal. Once you have given a muscle relaxant, you can use neuromuscular monitoring. All right. So never put your personal biases in the exam. Never say things कि ये मैं नहीं करूंगी. Right? तुम 40 मिनट के केस में एबीजी 2 बार बोल दी, जो कि तुम एक्चुअली में नहीं करोगी, तो फिर न्यूरोमस्कुलर मॉनिटरिंग के लिए क्यों मना करोगी? करूंगी. ठीक है. Since these patients are known to have coagulopathy because of platelet dysfunction, so although the coagulation profile is normal, we'll have a low threshold for blood transfusion in case there is increased risk of bleeding. And before the surgery, I would like to give IV tranexamic acid 1 gram to decrease the antifibrinolytic effect of the incision and the subsequent issues. All right. Then you go to intraoperative and postoperative analgesia. So my plan of intraoperative analgesia would be a combination of low dose of fentanyl along with multimodal analgesia with ketamine, with paracetamol, with dexmedetomidine and regional nerve blocks in the form of subcostal tap or rectus sheath block. For postoperative analgesia, I would do it on SOS basis, keeping paracetamol and IV lignocaine infusion as my mainstay of postoperative analgesia and only using opioids for breakthrough pain. ठीक हो गया. आपने ये भी बता दिया कि मैं यूज भी कर सकती हूँ, ये भी बता दिया कि ज्यादा यूज नहीं करूँ. Postoperatively, I will monitor the patient, preferably in an ICU for the first 24 hours, keeping a check on the vitals, the urine output, post-operative investigations like serum electrolyte and serum creatinine to see the status of CKD. I will maintain normovolemia. I will keep the patient warm and hydrated. I will maintain post-operative analgesia. Early mobilization and early feeding help in avoiding the complications associated with nephrotoxic drugs. एंड पूरे में कहीं भी नेफ्रोटॉक्सिक ड्रग्स की बात नहीं आई है, जो कि आपका पहला स्टेटमेंट होना चाहिए. आई विल अवॉइड नेफ्रोटॉक्सिक ड्रग्स. व्हाट आर द नेफ्रोटॉक्सिक ड्रग्स? आपने आईवी डाइक्लोफिनेक दे दिया. मैं नॉर्मली अपने पेशेंट को डाइक्लो नहीं देता हूं.
डायलिसिस है तो
क्यों? डायलिसिस है तो किडनी डैमेज नहीं होगा क्या? आप बताओ, कोई पेशेंट डायलिसिस पे है, हाँ, कोई पेशेंट डायलिसिस पे है तो उसको डाइक्लोफिनेक का किडनी डैमेज नहीं होगा क्या? डाइक्लोफिनेक इज अ प्रोस्टाग्लैंडिन inhibitor which is directly related to acute kidney injury. You will never say I can give diclofenac. Dialysis पे हो या नहीं हो, डाइक्लोफेनाक नहीं देंगे. समझ गए? डाइक्लोफेनाक से प्लेटलेट फंक्शन भी डाउन होता है, कोएगुलोपैथी भी बढ़ती है. डाइक्लोफेनाक से you have risk of more kidney damage. तो कभी don't never ever, it is a nephrotoxic drug. जब आप नेफ्रोलॉजिस्ट ओपिनियन देते हो तो क्या लिख के भेजता है? अवॉइड एमिकासिन, अवॉइड एम्फोटेरिसिन बी, अवॉइड डाइक्लोफिनेक. 3 ही तो ड्रग है जो अपने हॉस्पिटल में जो कि नेफ्रोटॉक्सिक है. उसमें से आपने एक ड्रग का नाम ले लिया कि मैं दूंगी, है ना? कभी नहीं दोगे उसको. ठीक है. सो यू अवॉइड नेफ्रोटॉक्सिक. या
सर, थायोपेंटोन का हाई वॉल्यूम ऑफ डिस्ट्रीब्यूशन है, मतलब जस्ट रिफरिंग आर्क में ऐसा मेंशन है, इट्स हाई वॉल्यूम ऑफ डिस्ट्रीब्यूशन, स्टिल यू गिव लोअर डोज
बिकॉज़ हेमोडायनामिक फ्लक्चुएशन.
हाँ, सो बिकॉज ऑफ दैट ना,
बिकॉज ऑफ दैट कि आपको रिक्वायरमेंट ज्यादा है, बट उतने रिक्वायरमेंट में हीमोडायनेमिक्स भी बहुत ज्यादा जाएगा, बिकॉज इट इज अ मायोकार्डियल डिप्रेसेंट ऑफ लिटिल सीवियर सॉर्ट, है ना?
ठीक है.
तो इसमें पढ़ने का इसमें ज्यादा जाने का. हाँ,
ओके. सिवोफ्लोरिन फ्लोराइड आयन प्रोड्यूस करता है, लेस, इतना सिग्निफिकेंटली नहीं होता है, बट स्टिल एज कंपेयर टू डेस्फ्लोरिन. सो हमको वी शुड बी मेंशन दैट व्हेन वी आर टेलिंग. नहीं ना? ओके.
See, sevoflurane, highest fluoride ion production is by methoxyfluorine, followed by sevoflurane. Sevoflurane gets metabolized 5% in the body. And even after 4 hours of sevoflurane anesthesia, they have not shown significant levels of fluoride ion in the blood. So technically ये theoretical complication है. तो why again put your foot in your mouth? लॉर्डोसिन के बारे में बात मत करो, फ्लोराइड के बारे में बात मत करो. कंपाउंड है इसलिए बोल दो जिससे उसको पता होना चाहिए कि आपने पढ़ा है सोडा लाइम का इंटरेक्शन, बस. ठीक है.
ठीक है. और सर एक रिक्लोराइजेशन है विद नियोस्टिग्मा से, मुझे समझा नहीं, मतलब आई हैव रेड बट
What they are saying is it's actually not recurization. It's very simple because your pharmacokinetics of muscle relaxants has now changed. So there is a possibility कि later on neostigmine का तो action खत्म हो गया, but muscle relaxant का action वापस आ गया. That is why we say that we always try to guide our neuromuscular blocking therapy using neuromuscular monitoring, and even in post-operative period we keep a check for 4 to 6 hours for residual neuromuscular block. Just that, nothing else. Recurarization का फंडा वही है कि आपका सपोज आपने रॉक्यूरोनियम दिया, आपने जब नियोस्टिग्मीन उस समय दिया तो रिवर्स होके पेशेंट ब्रीथ करने लग गया, एक्सट्यूबेट कर दिया. 2 घंटे बाद नियोस्टिग्मीन का एक्शन खत्म हो गया, रॉक्यूरोनियम का अभी भी है, तो पेशेंट विल अगेन हैव अ शैलो ब्रीदिंग एंड माइट गो इनटू रेस्पिरेटरी डिप्रेशन. दैट इज व्हाट रिकurarization is. ओके, सो आई थिंक आपने बहुत अच्छा केस प्रेजेंट किया एंड यू वर thorough on most of the things. What you did with me, if you just fine tune the speaking aspect of it, मतलब जो चीजें तुमने अभी मुझे बोली हैं इसको आईने के सामने खड़े होके 3-4 बार बोलना है, so that the flow of thoughts, जैसे मैं जो बोल रहा हूँ, flow of thoughts जो है ना थोड़े streamline हो जाते हैं, तो आप calm down हो जाते हो. जब आप calm down होते हो तो आप धीरे बोलते हो, जब धीरे बोलते हो तो सोचने का टाइम मिलता है, सोचने का टाइम मिलता है तो सही बोलते हो. ठीक, आपको थोड़ा सा रिलैक्स्ड होके बात करना है, सो दैट एग्जाम में ऐसा नहीं हो कि आप आगे 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 का सोचते चले जाओ और जो बोल रहे हो गलत बोलते चले जाओ. ठीक, कहीं पे आपने 40 मिनट का सर्जरी बोला, कहीं पे आपने 40 आवर बोल दिया. छोटी छोटी बातें हैं, क्यों? क्योंकि यू आर थिंकिंग अहेड ऑफ टाइम. ठीक है, सो योर प्रेजेंटेशन वॉज वेरी गुड, योर केस वॉज वेरी गुड, योर कंटेंट वॉज वेरी गुड. ओनली थिंग दैट वॉज नीडेड इज अ प्लान ऑफ हाउ टू स्पीक, व्हाट टू स्पीक, सो दैट यू इंक्लूड एवरीथिंग. ठीक है, we will do again a case discussion on a topic that you want to do, and next time I would expect you to at least revise and in the sense कि सारे potential questions को एक बार आईने के सामने 2-3 बार बोल के जब आप करोगे, you will feel better about it. All right,
sir, this was very helpful session. मतलब it has given a good orientation, like difference between concern and goals.
yes,
I in my mind it was safe, but
yes.
this you have like helped very nicely, and it will, I think, really
And
help
I
us
am
these
telling
kind
you,
of sessions.
practical exams are easier because you can divert your viva. You can
Yes,
divert
sir.
your viva. ठीक, जो नहीं आता है वो मत बोलो, जो आता है उस पर खत्म कर दो. जैसे आपको लॉर्डोनोसिन टॉक्सिसिटी पता है, तो आप एट्राक्यूरियम पे आके 1 सेकंड रुक जाओ. सर, आई वुड प्रेफर एट्राक्यूरियम इन अ केस ऑफ सीकेडी बिकॉज इट हैज गॉट अ नॉन ऑर्गन डिपेंडेंट मेटाबॉलिज्म इन द फॉर्म ऑफ हॉफमैन्स एलिमिनेशन. Wait for a second. Automatically the examiner will say, but is there a concern of CKD in a patient with atracurium? Then you will say, yes sir, there is a theoretical risk of laudanocin toxicity because of accumulation of laudanocin in CKD, but that has never been shown of any significance in human beings, but has been shown in lab rats. So that would not be a big concern. But if I have a long duration of surgery, I will prefer cis atracurium that doesn't cause laudanocin toxicity. ठीक है, तो आपने क्या किया, आपने उस पॉइंट को रोक के यू डाइवर्टेड और वाइवा देयर. ये सेंस जो आता है वो तब जब आप आराम से जवाब दे रहे हो, तो क्या होता है, आप स्पेस आउट कर लेते हो. जल्दबाजी में कुछ भी मत बोलो, हर चीज में 2 चीज याद रखो, 2 पॉइंट्स पर टॉपिक पर क्वेश्चन. तीसरे का टाइम मोस्टली एग्जामिनर नहीं देने वाला है, और तीसरा मोस्टली आपको ही गलती करने वाले हो. 2 में यू विल ऑल्सो ऑलवेज सी करेक्ट थिंग्स. ठीक है,
ठीक है सर. इनका रीनल फंक्शन टेस्ट वगैरह डिटेल में एक्सपेक्टेड है क्या? मींस ये एनेस्थेसिया मैनेजमेंट के अलावा
अगर पूछ लिया तो आप बता देना, बाकी तो कुछ ऐसा रीनल फंक्शन
सर
टेस्ट में
और
होता
कुछ
नहीं.
डिटेल में, मतलब दिस तो डिटेल में वी शुड नो एनेस्थेसिया एक्सेप्ट फ्रॉम दिस, मतलब जस्ट आस्किंग यू कि और कुछ डिटेल में वी शुड नो
डिटेल में
स्पेसिफिकेशंस
कोई
एकदम.
चीज नहीं करनी होती है. द ब्यूटी ऑफ प्रैक्टिकल इज हर चीज सुपरफिशियल करनी होती है, बट हर चीज टच करनी होती है ना. डिटेल में तुम देख रही हो, मैं जब तुम्हारा वाइवा ले रहा हूँ अभी, वी हैव बीन डिस्कसिंग दिस केस सिंस ऑलमोस्ट 1 hour and 20 minutes. इसका 1/5 टाइम आपको एग्जाम में मिलने वाला है. आपसे एग्जामिनर 20 से 25 मिनट का वाइवा लेने वाला है, तो आप बताओ कोई भी चीज डिटेल में जाएगा वो? नहीं. तो वो बस ये देख रहा है कि आप मरीज को मार तो नहीं दोगे. तो अगर आपने डाइक्लो दे दिया, मरीज मर जाएगा. आपने हाइपरकेलेमिया में स्कोलिन दे दिया, मरीज मर जाएगा. आपने पेशेंट को फेंटेनिल पीसीए लगा दिया, मरीज मर जाएगा. आपने प्री ऑपरेटिव डायलिसिस नहीं की, मरीज मर जाएगा. आपने हाइपरकेलेमिया मैनेज नहीं किया, मरीज मर जाएगा. सो रिमेंबर ऑलवेज द एग्जामिनर विल फोकस ऑन हाउ यू मैनेज एंड एंटिसिपेट अ कॉम्प्लिकेशन, बिकॉज when he gives a go ahead to you today, after you finish your practical. From tomorrow, you can go out in the society and be an anesthetist. So he has that moral liability on his head that whether you as a candidate are actually going to keep the patient alive or not, because his signature is going to decide whether you are officially an anesthetist or not. ये बात कभी मत भूलना. वो आपको जज ये नहीं कर रहा है कि आपने कहाँ से पीजी किया, कितनी पढ़ाई की, आप कितने स्मार्ट हो, आपके कितने दोस्त हैं. नहीं, वो बस देख रहा है भाई तू कल को जाके किसी को मार मत देना. So you should know the major complications, how to anticipate them and how to manage them. ठीक? चलो.
Thank you so much,
Thank
sir.
you so much.
Looking
We'll
forward
meet
for
soon
more
again.
classes.
Yes, yes. Next week we'll do another case. Okay.
Yes, sir. Thank you so
Thank you
much,
so
sir.
much, Kritika. Bye. Bye.